Morning, everyone. So, as Dr. Deep said, my presentation this morning is on prostate cancer in Jamaica, and we'll be looking at the local profile of prostate cancer, presenting the uh, transrectal ultrasound biopsy data from one institution. So, in the great big world, where is Jamaica? We're this tiny dot at the tip of the red pointer, but the schematic so on the lower uh, portion of the slide actually show Jamaica in comparison to the rest of North America. So my objective this morning, basically to give you background on Jamaica and Jamaicans, also to review the incidence and mortality rate of prostate cancer in Jamaica and compare that to other countries. Also to present the local data on prostate biopsy findings at one institution and to identify the need for prostate cancer screening in a high-risk population like mine. Jamaica spans a total of close to 11,000 square kilometers. We have 14 parishes. The population is just about 2.7 million, of which 93.7% are Black, 6.1% are mixed with other ethnicities. Um, but the highest population density is basically in Kingston and Montego Bay. So basically on the southern tip and northern western tip of the island. In terms of age distribution in Jamaica, the population is mostly of young people, really, less than 50. Only about 7.94% are over 65 years old. The median age in male is 25.1 years and female 26.1. The life expectancy at birth for males about 72 years and female higher at 75. The healthy life expectancy though decreases to 64 years. And the reason for this, as shown here in the WHO regional life expectancy at birth, in 2012, we noted that the healthy life expectancy was reduced by 11 years, and this is due to the years lost due to morbidity and disability from illnesses. And as you can see here, well, our females live longer than the males. And the causes for this reduced life expectancy is largely due to cardiovascular disease and diabetes, followed by cancers in the lighter shaded purple. The WHO top 10 causes of death in Jamaica is actually headed by strokes and ischemic heart disease, but prostate cancer is right there as well. And we've been seeing an increase in mortality rate due to prostate cancer. In the Jamaica Health and Lifestyle Survey of 2007-2008, Wilkes et al. Did a cross-sectional interview administered survey using questionnaires looking at the demographics, chronic disease prevalence, health-seeking behavior of Jamaicans, reproductive health, socioeconomic status, and lifestyle and health changes. They also documented blood pressures, blood glucose level, as well as cholesterol. And they surveyed 2,848 individuals between the ages of 15 and 74. And what he found was that there was an increase in the prevalence of these chronic non communicable diseases: obesity, hypertension, high cholesterol, and diabetes. Hence, the reason for the increased mortality due to these causes. And importantly, the similar survey was done in 2001, and this was actually an increase. The survey is currently in progress back home, and we're anxiously awaiting what that will show us this time. Also, from this survey, uh, they actually realized that the majority of male, 79.2%, never had a rectal exam. Well, mind you, our population mean age is about 25 anyway, so they would not be needing one. However, as men get closer to 45, the proportion of men who do digital rectal examination actually increases. So that's a good thing. In terms of diet, we have no special diet. But from this survey, it showed that 30% of the persons who were surveyed actually used frying as a method of preparing the main protein, which is fish and chicken. 74% used vegetable oil for this, and about a quarter of the survey participants actually used fats on their bread. So, but alarmingly, 99% had well below the daily intake of fruits and vegetables. In terms of health financing in Jamaica, we have a large public and a very large private health sector as well. The public health sector is funded largely by taxes. In 2004, user fees were abolished from all public health facilities, and this actually increased access to these areas. However, they do still have a large out-of-pocket payment as well that is required. So even though they're not paying to get access, they do have to pay for some other facilities. From our health survey as well, it showed that only 19% of Jamaicans have private health insurance, and men were more likely to benefit from this than women. From previous studies, and it was borne out in this lifestyle survey as well, that Jamaican men have very poor health-seeking behaviors. However, those who had private health insurance were more likely to seek health care. In terms of expenditure on health, we fall well below that of the Americas. As you can see in the blue line, that actually represents Jamaica compared to the green line for the rest of the Americas in terms of the WHO region. In 2003, we have the introduction of the National Health Fund, which provides substantial discounts for medication for most chronic diseases. And in 2005, medications for the treatment of prostate cancer was also introduced at that time. As a result of that, we see the costs in major antiandrogens and the LHRH reducing significantly. So prior to 2005, Gaserelin was like close to $100,000. And after the subsidy, it has fallen by more than a half. And chemotherapeutic drugs have also been introduced as a result of the National Health Fund, and this has reduced the cost as well. Morrison et al. Back in 2011 actually looked at the impact of the National Health Fund policy on hormonal treatment in prostate cancer in Jamaica. At that time, she looked at all the biopsy-proven high-risk prostate cancer patients who were offered hormonal therapy from 2000 to 2007, and then looked at the proportion of patients who chose surgical castration versus medical castration given the subsidy that was introduced by the National Health Fund in 2005. And prior to 2005, surgical castration was pretty common. 181 patients, roughly about 60% of those who were offered hormonal therapy. After 2005, this decreased, and medical castration was more commonly offered because patients were more able to afford this from the subsidy. And also, interestingly, the prior to 2005, flutamide, and we know that of its hepatotoxicities was more common, but after the subsidy, bicalutamide and sapropterin acetate was more commonly used, and also the use of the LHRH analogs had an increase after 2005 as well. So Jamaica is famous for music. Bob Marley. We have the fastest man in the world, Usain Bolt, and more fast men, Asafa Powell, Johan Blake, the fastest woman, Shelley and Fraser Price, and Elaine Thompson. And we're known for our beautiful waterfalls as well. And when it comes to food, we have one of the best tasting food in the world. And I will just say that. And when people think about Jamaica, they think, yeah, Jamaica, no problem, man. We have no problems. But indeed, we do have problems. And our problem is that in Jamaica, prostate cancer is the leading cause of male cancers. We have a whopping 78.1 new cancers per 100,000 men. Well, it's also the leading cause of cancer mortality at 53.9 per 100,000 men. Um, when we look at this curve, well, I'll let you know in a bit. Well, not for Canada. I didn't go too much into Canada, but to US, I'll let you know in a few. Um, in 1994, we had this incidence of prostate cancer in Jamaica close to like 300. And this alarmed the world because they're like, oh my God, what is happening in Jamaica? Why is our incidence rate so high? Unfortunately, they had a double data entry system when Dr. Glover came to Jamaica. Um, and this basically doubled the incidence of prostate cancer in Jamaica. So Hanchard, Gibson, and Blake et al. Went back to the Jamaica Cancer Registry and actually quoted the more accurate figures uh, there.
Yeah.
Right.
So the Hopkins did a email on screwed it up.
Yeah.
This one. Who's that guy, Patrick?
Patrick C. Walsh, we all knew him. Yeah, and actually, Prof. Lawson Douglas and Mark Cadogan are actually Canadian trained Jamaican urologists. And Hope Russell, Trevor Tullow, they're retired Jamaican urologists now. So the curve from 1991 to 2007 actually depicts the more accurate incidence rate of prostate cancer in Jamaica. And the trend is an upward one. Looking at our local data from the cancer registry, prostate cancer outweighs all other cancers in the male population. In the combined population, prostate cancer again is the most common cancer. Looking at the US incidence and mortality rate, they actually separated theirs based on ethnic groups. And you can see a wide separation of the curve between blacks in the blue triangles versus the whites in the red squares. And they do have a higher incidence in Jamaica, but this just goes to show that there is indeed a higher incidence of prostate cancer in a black population than the white. Looking at the mortality as well, there's a higher incidence, well, higher mortality rate in the black than the white. So looking at the incidence, comparing Jamaica to other countries, US, Sweden, Australia, we see our incidence is only second to US alone, which is very high. Canada, I think, is 23.9, about there, which is much lower than our small country. Looking at the mortality rate, this is very alarming. We supersede everyone else. So that
Canada just lumped in Australia.
it didn't actually say, but I noticed like most areas that I was looking for like a larger representation of countries in the world, on Canada was not there. But I thought because they had a low incidence, but when I actually looked at Canada alone, I realized that they, unfortunately, I realized that it's actually just as competitive in these areas as the rest of the world. But this was alarming for us. So In our urology department, prostate cancer is indeed a major health issue. It's actually a major part of the workload in all urology departments across the island. Uh, we know it is potentially curable when it's detected early. Anecdotally, at the Kingston Public Hospital, we see more patients with advanced disease and those with high risk parameters at their initial presentation. However, we have very little data to support this idea, and also little data on the disease profile of prostate cancer in Jamaica. The disease pattern is for the patient seen at the Kingston Public Hospital is likely to represent that of the general population. And looking back at Jamaica, we have three main urological centers: Cornwall Regional in Montego Bay, and the Kingston Public Hospital in Kingston, and the University Hospital of the West Indies in St. Andrew. There is a small department in Mandeville, but it's not as active as these three. Uh, KPH, Kingston Public Hospital, sees roughly about 60% of the population. In 2013, we saw more than 1,100 men who presented due to elevated PSA or lower urinary tract symptoms. And in that year, that actually accounted for 47% of the new attendees to our clinic. And during that year, we did 386 TRUS biopsies. And this was my team who helped me to collect data. And basically, we looked our objectives at the time, given how our anecdotal finding, was basically to document the detection rate of prostate cancer at Kingston Public Hospital and to see how this compared internationally. So we documented our disease patterns based on age, PSA, mode of presentation, histological findings, determine the proportion of patients who were amenable to curative treatment, and possible to identify some risk factors. So we did a retrospective review of patients from January 1, 2013 until June 30, 2014. In fact, this is ongoing, but I've just truncated a part of the data where I have most of the information for. So we looked at all prostate biopsies that were done from the booking and those who kept their appointments, and we completed a computerized data sheet. After approval, of course. And we then re-stratify patients based on those who had early presentation, locally advanced, metastatic disease from all the parameters that we had. And the analysis for our data was done at the epidemiology unit at the University of the West Indies. For the prostate biopsies that were done, they were only ultrasound guided. We don't have MRI fusion as yet. And all biopsies done were 12-core biopsies. Most biopsies were done by residents in the program, but we also had medical officers who were at least 2 years post-graduation who worked in the urology department doing those, and our consultants or attendings also did them. Of note, though, those medical officers who were not in a urology program, when they were doing biopsies, they were supervised by the consultants. All samples were sent the same day in formaldehyde to our lab, and the main lab they were sent to was the National Public Health Lab. Unfortunately, there's no specialized genitourinary pathologist, so any of the general pathologists really would read our slides. And what we found from our data collection was for the year 2013, we had 386 biopsies done. And from January to June of 2014, we did another 139. Of this, however, 116 patients had missing data. We had 409 towards the end, but 17 had no histological records. And so we had only 392 files to assess. Of that, the average age of those patients was 69.4 years, with a range of 40 to 91 years old. The mean age at cancer diagnosis in this group was 70.3 years, with a range of 48 to 88. The mean PSA was 94.3. with a PSA range of 0.2 to 9,600. In terms of the distribution of the patients by parish, Kingston and St. Andrew had the largest number, followed by neighboring parishes of St. Catherine, Clarendon, and St. Thomas. There's zero for Westmoreland, St. James, and Trelawney because they are largely seen at the Cornwall Regional Hospital. Symptoms at the time of presentation, most patients presented with lower urinary tract symptoms. Of note, though, of all the patients who presented, just about 50% had abnormal digital rectal examination findings. And for those who had cancer, more than 64% had abnormal digital rectal examination findings. Of this group, 24 patients presented with symptoms that were suggestive of metastatic disease. In terms of our biopsy detection rate, cancer was detected in 45% or 176 of the 392 patients. 186 patients, though, had a benign histology, and we saw a few ASAPs that had repeat biopsies and a few pins as well. In terms of the clinical staging from digital rectal exam, most patients had a palpable nodule by the time they presented to the urology department, and we had a 32% of the patients presenting with T3 or T4 prostate on examination. In terms of the PSA distribution for the biopsy outcome, 99 patients presented with a PSA greater than 20 nanograms per ml, which is very high. Benign histology PSAs were in the lower category. In terms of the minimum and maximum PSAs based on the histology, cancer had the lowest being 3.5 and maximum the 9,600. Of course, that's where it came from. Cancer, it couldn't be anything else. In terms of the Gleason scores we saw, this was a little bit surprising for us. We thought, based on the PSA level and some of the DRE findings, we would have more Gleason 8, but that only accounted for 38 of the patients, and the vast majority were Gleason 3+3. But when we risk stratify them, the vast majority were already high risk at the time of presentation. 65% of those who had their TRUS biopsies done during that period, and only 18 or 10% had low risk at the time. In terms of distribution by stage, though, most were still early stage, even though they were high risk. And 46 patients, or 26%, actually had metastatic at the time of diagnosis. In terms of symptoms and those who presented with a screening PSA, we found that the high-risk patients, well, the average PSA for screened patients was far less than those who presented with symptoms. Also, the proportion of patients who had high-risk cancer versus those who in the screen population was less than those who had presented with symptoms. And again, those who presented with metastatic disease, there were those who presented with symptoms. They didn't just have a screening PSA, which is very alarming for us as well. But how does this compare to US data? We found that the standard detection rate in the US was about 28 to 40% on their TRUS biopsies, whereas we had a 45% detection rate in our series. In the US, 26% of the men actually had high-risk disease, where we had 65%. When cancer is detected in the US population, 90% is organ confined, whereas in our series, only 53.9% was organ confined. So we tried to find out what were the possible risk factors. We looked at the family history. Unfortunately, it wasn't stated in 71 of the patients who were seen. However, 13 of 105 patients had a positive family history. And of this amount, only 38% had high-grade disease. And the average age of cancer in these patients who had a positive family history was 67.9 years, and the average PSA was 94.5. We had some patients who were taking 5-alpha reductase inhibitors, and we looked at the total number of patients and those who had cancer who were on 5 ARIs. And the detection rate for these patients were on 5 ARIs. And we found that we had less patients who were taking the 5-alpha reductase inhibitors, and the detection rate of cancer in these patients was actually lower than those who were not on 5 ARIs. But the numbers are so different that I don't think we can actually utilize this much, but just to mention it here. So the vast majority of our patients were not on 5 ARIs. Looking at the grade of cancers for those who were on the 5 ARIs, we had a detection rate. The percentage of high-grade cancers was actually 39.2% for those who are on 5 ARIs. So given all of that, and what we have currently in Jamaica is that we do advocate screening. I know here in Canada, and especially in the US, it's very controversial, but we have to admit we're a high-risk population. So we start screening at 40 years in Jamaica with an annual PSA and digital rectal examination. And this is actually advocated by the Jamaica Urological Society. The Jamaica Cancer Society is available for weekly screening, and they have clinics at least twice per week that men can walk in, pay a minimal fee, and they have their screening PSAs and rectal exams done. In terms of cancer treatment that were offered to these patients, 24 patients had a radical prostatectomy, 23 had radiotherapy, but a whopping 92 had ADT alone. We have 25 patients who were unsure whether or not they wanted to undergo surgery, radiotherapy, or what they wanted to do. So in conclusion, in Jamaica, prostate cancer is a disease of the aging population. Our detection rates from prostate biopsies are high. We have a high incidence of high risk and advanced disease. And as a result of that, we advocate screening. However, only few men present for screening. And the minority of cancers are when detected, are amenable to cure, unfortunately. And thank you, Dr. Patterson, Dr. Sue, for your input.